लिखा हुआ है join this week. What? Let's say
consultant gastroenterologist at Apollo Multi-Speciality Hospital in Kuala. Today we are all here to discuss on an interesting topic, which is GERD. As we all know, that GERD is a very common GI disorder we encounter. It has a prevalence of about 18 to 30% worldwide. And to speak about this, we have two eminent speakers. The first talk will be given by, the first talk will be on the surgical aspect of the GERD management by Dr. Arun Prasad, sir. Dr. Arun Prasad, sir, is a clinical lead and senior consultant in GI bariatric and robotic surgery at Apollo Hospital, New Delhi, having at least 36 years of surgical experience. He has an experience of performing over 10,000 laparoscopic surgeries that include 6,000 laparoscopic cholecystectomies and over 2,000 laparoscopic hernia surgeries, thoracoscopics, and 1,500 bariatric surgeries. He was former president of Obesity Surgical Society of India, president of International MGB Club of Bariatric Surgery. Presently, sir is vice president of the IRIS. So I'd like Dr. Arun Prasad, sir, to deliberate his talk on the surgical aspect of GERD management.
Hello.
Hello?
Can I start?
Yes, sir, please.
Okay. Thank you very much for the kind welcome and congratulations to the group, Dr. Jain and Dr. Jitender, for organizing this series of webinars with the collaboration using Gapio and ARIS. So we'll start with my topic on GERD management, gastroesophageal reflux disease, that is. So how do we define this? So gastroesophageal reflux disease is a chronic gastrointestinal disorder characterized by the regurgitation of gastric contents into the esophagus. But many people will say, I have it every time. This is something that happens to me every time I go for dinner or I have a big drink or every weekend. So is acid reflux the same as GERD? During an episode of acid reflux, you might feel a burning sensation in your chest, which is heartburn. This can occur after a big meal or drinking coffee or alcohol. The most common symptom of GERD is frequent heartburn, 2 or more times a week. Other signs and symptoms that include regurgitation of food or sour liquid, difficulty in swallowing, coughing, wheezing, and chest pain, especially when lying down at night. What's the pathophysiology? It's due to impaired lower esophageal sphincter function and transient lower esophageal sphincter relaxations, which take place. Hiatus hernia, if present, causes GERD. Also, impaired esophageal mucosal defense against the gastric reflux aid. And finally, defective esophageal peristalsis. So these are the mechanisms that cause GERD. What investigations do? We do a barium study, we do an endoscopy, pH manometry. Dr. Batra will be joining us soon. He'll talk about the endoscopy and pH manometry in more detail. And he will tell us what kind of looks we get, all these things. Further investigations are barium study and the pH manometry. As you can see, there you have a 24 hours manometry that tells us about what kind of pH is there in the lower esophagus. When it comes to management, lifestyle changes most important, because a lot of this problem is lifestyle related and they get better by lifestyle changes. Sleep patterns, early to bed, early to rise, what our grandparents have taught us. After meal physical activity. So after having dinner, just don't go lie down in front of the TV and go to bed. You must try and go for an evening walk or a night walk. Last meal time. There should be a gap of at least 2 hours between your last meal and going to sleep. Finally, bed end elevation. So bed end elevation does not mean using two pillows, because two pillows means neck elevation, head elevation. It does not elevate your body. So bed elevation basically means that you need to put two slabs of thin bricks under the foot end of the bed towards the side of the head, so that the entire bed tilts. So it's not just the head tilt which we are looking at by putting two pillows, which does not work. It is the bed end elevation. This is wrong. What you need to do is this. I hope that's clear. PPI, prokinetics, Dr. Batra will talk about that. Coming to more interventional procedures, we have magnetic sphincter augmentation. So I do a laparoscopy. I put this magnetic beads around the lower esophageal sphincter. And what happens? Then we have the, sorry, I think we were looking at this video. I'll show this to you in the end, but I'm sure Dr. Batra will talk about it. Basically, if we go to the picture, what happens here? The food passes down, the magnetic beads move away. And once the food has gone inside, this is the food going in, the magnetic beads will close. So this is magnetic sphincter augmentation. And the other one which I'm talking about is transoral incisionless fundoplication, which is done by my colleague, Dr. Batra, whereby you put in the endoscope there and stitch this. Look at that. This is technology. So this is a relatively new procedure, good for people who are not fit for formal surgery, and also those who don't want surgery, plus mild cases. It can always be converted to a regular surgery later on if it fails. Indications for surgery: failed medical management. Then we decide for surgery despite successful medical management. Now, this is a situation where somebody is taking PPI and has got problems, because you can't take PPI lifelong. Once you do that, you will lose your acid in the stomach, leading to iron deficiency, B12 deficiency, calcium, vitamin D, all sorts of metabolic issues, because God has made acid in your stomach for a purpose. So you can't keep it suppressed all the time. Also, complications like Barrett's esophagus or peptic stricture have medical complications attributable to a large hiatal hernia, or atypical symptoms such as asthma, hoarseness, cough or aspiration, chest pain, dental erosions, and a reflux, which is documented on 24 hours pH monitoring. So there are a lot of controversies: medicine or surgery, robotic or laparoscopic, partial or complete. So these are the points of debates which we keep having at our medical and surgical conferences. An important question which all of you would like to know is, who responds well to surgery? So which is the patient who should go for surgery? Is this question which all physicians, all general practitioners, all gastroenterologists, and all patients also want to know. So manometry and pH studies have been proven. Those who are responsible to pharmacotherapy. So if somebody does not respond to reduction in the stomach acid, he will not respond to surgery either, because it's not the acid that is causing the problem. Typical symptoms respond better than atypical symptoms. Presence of hiatus hernia. I personally think presence of hiatus hernia becomes an indication for surgery, because these are the patients who do best after surgery. So that's the type of hiatus hernia. You can see in the middle what we call as a sliding hiatus hernia, and what you can see on the right is known as a rolling hiatus hernia. So these are the people who respond well to surgery. A good slide to remember. Then full versus partial. Full fundoplication is known as Nissen. Toupet and Dor are partial fundoplication, and the latter are done if there is motility issue. So if you can see this diagram, on the left you see what is known as a complete 360-degree stomach wrap, and that wrap prevents the stomach from going up into the chest. Dor fundoplication, as you can see, this is a 180-degree fundoplication being done from the front, which we do usually when we are doing a surgery of achalasia along with fundoplication. Toupet fundoplication on the right, what you see is a 270 degrees wrap, and this we do in people who have some esophageal motility issues, because in these patients, if we do a Nissen complete fundoplication, they can run into dysphagia-like symptoms. Then comes the question, should we do this laparoscopic or should we do this robotic? Now, laparoscopy is widely available, it's cheaper, it's established worldwide. However, we have non-articulating instruments that makes our surgery longer, and you are dependent upon an assistant all the time for a complex surgery. Robotic has true 3D ID articulating instruments, 4-powered control, takes much less time, very good in the obese and super obese category, in the revision cases also. However, it is a little more expensive than the laparoscopic. What people would be glad to know is that now insurance is covering robotic fundoplication, and we have done lots of these surgeries with insurance covering robotic fundoplication. So that's good news for many. Let's see what this looks like. Just one sec. I have to see why this video is not working. Okay. What I'll do is I'll get onto these videos separately. So this is what our robotic suite is. These are our robotic instruments.
Sir, we are not able to see the video.
You're not able to see the video?
No, it's just the slide, the PowerPoint presentation which is visible.
Okay, just one sec. I will change that. Just give me a second. I'll change this also. Is this visible now?
Yes, sir.
Can you see this?
Yeah, visible.
Okay, fine. So this is how robotic surgery is done, whereby we make a few holes in the abdomen, put in what is known as a trocar and cannula, and that's the robot you can see from the background, which is being brought to the patient. And this step is known as docking of the robot, whereby we connect the robot to the patient instruments are introduced inside the abdomen. Our assistants can see the surgery being done there. The robot lifts up the abdomen, helps us to do the surgery. And after connecting the robot to the patient, then the surgeon goes and sits on the console. So here you can see that I am sitting at the robotic console and starting the robotic surgery from a distance. And that's the robotic surgery. This is what the picture looks like to the assistant outside. And I have all my controls here. There are 7 pedals to control. And that's how the robotic surgery is taking place. The instrument movements are controlled through the console. Instruments go through these small holes, which don't even need any stitching. At the end of the procedure, we do what is known as undocking of the robot. So this is what a robotic surgery looks like. Wound is closed. And this is the final cleanup. Hardly any cuts visible. I shall now share with you a video of a giant hiatus hernia. Now, in the past, this kind of a giant hernia required a laparotomy and a thoracotomy. So you have to open the abdomen, you have to open the chest, cut open the diaphragm to be able to do this. And here you can see how nice, steady picture that doesn't shake. I'm able to pull the entire stomach down from that cave, through which the stomach had gone inside the chest. So this stomach was lying inside the chest. I can dissect into the chest right up to the pleura without any problem. And this is where technology has tremendously helped. These patients now can go home 2 days after surgery compared to a 2 weeks minimum stay that used to take place if we were to do a thoraco-abdominal surgery, a thoracic cut and an abdominal cut. So this, what you can see, the instrument is making a gap between the esophagus. We take this stomach and we are putting the stomach around what is known as a wrap. So we pull the stomach around behind the esophagus, and this is a 360-degree Nissen's fundoplication, what I was mentioning earlier. After this, the hernia is being closed. Again, here you can see how my robotic instruments suturing takes place in 360-degree angle. So I can take it from right to left, left to right, top to bottom, all directions. The fundoplication suture is taking place. So first we close the diaphragmatic hiatus, and now we are doing the fundoplication, stomach to stomach suturing, so that this stomach now never migrates up back into the abdomen. However, all surgeries have complications. So has this. You can get bleeding, you can injure the spleen, you can cause ischemia of the wrap, patient can get dysphagia, there can be recurrence. Most of these complications, rather all these complications, are preventable. It requires good training and a good center. So hopefully these complications do not occur. So to summarize, I would like to say surgery is not the first choice for GERD, but when indicated, it is the best choice. Indications are very clear. Pre-operative evaluation of the patient is very important. Counseling of the patient is important. Robotic surgery is technically superior to lap or open wherever available. And with that, thank you from my robotic team from Indraprastha Apollo Hospital. Change is inevitable, growth is optional.
Thank you, sir, for that excellent talk. So we'll take the questions at the end.
Okay, sure. I'll mute myself.
Okay, for the second talk, I'd like to introduce Dr. Yogesh Batra, who is a senior consultant in the Department of Gastroenterology and Hepatology at Indraprastha Apollo Hospital, New Delhi. His primary work has been in liver disease, endoscopy, inflammatory bowel disease, pancreatic disease, and GI malignancies. He's an avid researcher and renowned academician. His significant research contribution has been an epidemiological studies in the prevalence of HIV antibodies in school children and patients of cirrhosis in the city of Delhi. He has participated in numerous national and international endoscopy workshop and demonstration and as a guest speaker. He has participated and delivered talks in multiple national and international conferences. He's been instrumental in setting up the Batra Gastrosciences and Liver Center at Batra Hospital, and also been responsible for initiating the academic activities like DNB program at Batra Hospital and BLK Hospital. Over to you, sir.
Thank you, sir. At the outset, I would like to thank GAPIO and Dr. Sibbal for inviting me for this talk today. I will be talking about the. Yeah, can you see the slides?
So we can see your slides.
Okay. I will be talking about the medical aspects of GERD. First of all, the definition. So GERD is a condition in which there is reflux of gastric contents into the esophagus, which results in symptoms or complications. GERD can objectively be defined as the presence of characteristic mucosal injuries seen on endoscopy or abnormal esophageal acid exposure demonstrated on the reflux monitoring study. The cardinal symptoms of GERD are heartburn and regurgitation. So there's acid coming up and it causes retrosternal burning. And there is regurgitation of food from the stomach. Few patients also complain of chest. Now with these symptoms, the differential diagnosis could be rumination, which is the effortless coming up of regurgitation of food from the stomach. It could be achalasia cardia when there is constriction at the lower end of the esophagus, and because of that, food tends to accumulate in the esophagus and it comes up and causes heartburn, regurgitation, and pain. Eosinophilic esophagitis, reflux, hypersensitivity, functional disease, cardiac or pulmonary disease, or paraesophageal hernia. So as you can see, there's a wide array of diseases which can mimic symptoms of GERD. So one should be careful before we label anyone as GERD. There can be numerous extraesophageal manifestations of GERD, and my ENT colleagues are very fond of labeling anything which happens in a throat as a GERD. So they can be laryngeal and pulmonary symptoms. So they could be hoarseness, throat clearing, chronic cough, laryngitis, pulmonary fibrosis, and even exacerbation of asthma has been reported. It can be difficult to establish GERD as the cause of these, as they could also be because of a number of other causes. How do we diagnose GERD? So GERD is a combination of clinical, which is heartburn and regurgitation, endoscopy, which shows the presence of erosive esophagitis, reflux monitoring, which is pH metry, and finally, response to therapy. Only if you have all four, you should label somebody as GERD. When you encounter a patient of heartburn and reflux, almost all recommendations today say that you give them a 8-week PPI trial instead of going in for an investigation in the form of endoscopy. However, there would be certain patients with alarm symptoms who would warrant early endoscopy. And these alarm symptoms are dysphagia, vomiting, weight loss, bleeding, and anemia. So if you have any of these alarm symptoms, you should go in for endoscopy and other investigations straight away. So after 8 weeks, you wean off these patients and you do endoscopy for those where symptoms recur. pH monitoring is recommended for those patients who have symptoms, but there is no endoscopic evidence required. And this is what we see in endoscopy. So endoscopy is classified as per the Los Angeles classification system for esophagitis. So LA grade A means that there's one or more mucosal bleeds no longer than 5 millimeters. You can see here. LA grade B is one or more mucosal bleeds longer than 5 millimeters, but not bridging the tops of the mucosal fields. So there are breaches here more than 5 millimeters, but they are not joined. As you can see in LA grade C, where there are large mucosal breaks which are now joining together uh, above the tips of the mucosal folds. And grade D is when these breaks end up occupying more than 75% of the circumference of the esophagus. So if you have LA grade A, there is no GERD, as it is a near normal endoscopy. If you have LA grade D, then there is GERD. If there are symptoms, then there is response to PPI. If there is LA grade C, then it is definite GERD. And if it is LA grade D, then it is severe GERD. In addition to this, you can get Barrett's esophagus, which if more than 3 centimeters is also diagnostic of GERD. Timing of endoscopy. So ideally, one needs to stop PPI before you subject anyone for endoscopy, and this has to be done 2 to 4 weeks prior to endoscopy. The reason for that is that PPI cause a rapid healing, and the endoscopy would then diagnose non-acid erosive gastritis rather than GERD. Another reason for stopping PPI is that esophageal biopsies can be taken for eosinophilic esophagitis, which is one of the differentials for GERD and which is commonly neglected. In those centers where they are routinely taking biopsies for esophagitis, results as high as 5% have been reported in patients for GERD. The next investigation is esophageal manometry or high resolution manometry. Now, esophageal manometry is not a test for GERD. However, it is an ancillary investigation which helps to exclude achalasia, as achalasia can mimic GERD. So you might end up doing surgery for GERD, although the patient had achalasia. It also excludes other associated motility disorders in refractory GERD. And it should be done preoperatively in all patients, as absent contractility is a contraindication to fundoplication. This is how pacemaker or reflux monitoring can be done. So there are 2 kinds of devices which are available. One is the standard catheter, which is placed 5 centimeters above the G junction. It has a number of electrodes which go right up to the upper esophageal sphincter, and they can detect the amount of acid which is flowing. Now, apart from acid, these electrodes can also detect impedance, which is flow of simple liquid. So, even if there is a non-acid reflux, these electrodes can catch that out. The other way of doing pH metry is with the Bravo capsule. This is a capsule which is attached 5 to 7 centimeters above the G junction by the endoscope, and then the endoscope is removed. The capsule remains there, and it consequently detects all these episodes of reflux which happen, and the signals are transmitted wirelessly to this recorder, which is attached to the waistcoat. The advantage of this is that it can be done for 2 to 3 days. Consequently, while the traditional method, one usually can do the recording only for 24 days. Once you have done the reflex monitoring, there are 6 parameters which you see, and these are the number of refluxes, the number of prolonged refluxes, the longest reflux, the total acid exposure, the total acid exposure time by standing, the total acid exposure time by lying. And you calculate what is known as a Demister score, which is 13.3 in normals, and anything above 13.3 is indicative of acid reflux. Coming to the management of GERD, the basic thing in the management of GERD is diet and lifestyle. The second thing is pharmacological management. Third is endoscopic management. And finally, surgical management. Surgical management, Dr. Arun Prasad has already told us in his talk, so I would be dealing with the first three. Diet and lifestyle, weight loss is one of the most important things, especially for those who are obese. A moderate weight loss, about 10% of the current weight, results in a significant reduction in symptoms of GERD. Apart from weight loss, tobacco and alcohol cessation have also been shown to reduce the number of reflux episodes. Elevation of the head end of the bed to 30 degrees and sleeping on a wedge has been shown to be effective. Staying upright during and after meals, having multiple small meals instead of large major meals, and sleeping 2 to 3 hours after the last meals are some of the things which have been shown to be effective in controlling reflux. There are certain trigger foods, and these foods are coffee, chocolate, carbonated beverages, tea, acidic foods, and food with a high fat. So all these foods should be avoided in patients who have significant medication. So the number of drugs over the years have continuously evolved. We started with antacids, then came alginics, then came H2 receptor antagonists, and finally proton pump inhibitors. There's no question that proton pump inhibitors are the gold standard for treatment of GERD. So proton pump inhibitors have a healing rate of almost 12% per week as compared to H2RAs, which have a healing rate of about 6%. The next question which automatically comes up is which proton company? Each company is trying to peddle its own proton pump. So this also has been answered repeatedly in different meta-analyses and has been shown that despite having different rates of acid suppression, all PPIs have similar rate of symptom relief and healing. So whether you use pantoprazole, whether you use omeprazole, lansoprazole, all the same. PPIs bind to actively secreting proton pumps and hence should be given about 30 minutes before meals. Bedtime dosing is to be discouraged as the proton pumps are not working, so PPI is also unworking. It is recommended that PPI should be stopped 8 weeks for mild disease, and one should resort to on-demand or intermittent. Maintenance PPI should be continued in those with LA grade C and D GERD. So those with severe GERD, maintenance PPI should be. We know that 2/3 of the patient would relapse on stoppage of PPI in those with mild disease, and almost all would relapse in those with severe disease. So there's no question about stopping PPIs in those with severe disease, and those with grade C and D and Barrett's have to continue to PPI. Those with mild disease, one can stop and switch over to intermittent or on. There's a certain group of patients who have partial response. So they are somewhat relieved, but they're not completely relieved. So there are two options for them. One is switching PPI or increasing the dose of it. There's certain patients who have nighttime acid breakthrough. For them, H2RA at night is the key. It goes without saying that the use of lowest effective dose of PPI is recommended. Now, a host of side effects of PPI therapy. So there are a number of other drugs which we have been studying since our MBBS days. prokinetics, baclofen, sucralfate, and acids. Today, 2023, none of these are recommended for the treatment of GERD. On-demand TPIs have even been found to be effective in any just non-acid or reflux disease. There has been a great deal of discussion in the last few years on the side effects. So once we were studying at that time, TPIs seemed to be a wonder drug, and there were follow-ups of 18 years and 20 years without any side effects. But now a number of studies are coming up showing almost major side effects in every system. So cardiovascular events, including MI, stroke, and cardiovascular deaths have been reported. And the reason for that is that the PPIs block metabolism of ADMA, which results in accumulation of nitric oxide. Cardiovascular events because of lower efficacy of clopidogrel. So PPIs compete with clopidogrel because the pathway of excretion for both is the same. Clopidogrel efficacy decreases and it becomes less. So it does not prevent stent blocking the way it should be, resulting in a fresh heart. Kidney disease. Acute interstitial nephritis has been reported as an idiosyncratic drug reaction. And once acute interstitial nephritis sets in, it's chronic kidney. All infectious reported complications are because they reduce the gut acid. Because they reduce the gut acid, the bacteria can easily gain access to the body. So whether it is increase in enteric infections, presence of Clostridium difficile, SIBO, or small intestinal bacterial overgrowth, spontaneous bacterial peritonitis and cirrhotics, or pneumonia in older adults. All of them are because of the acid barrier of the gut being lost. Dementia has been reported in those containing PPIs for long periods of time, and this is thought to be because of alteration in H plus ATPase pump, which is needed for microcardial lysosomes. Bone fracture because of reduced calcium absorption, gastric atrophy, acid suppression, gastric atrophy is subsequently leading to H. pylori and gastric cancer. Vitamin D12 deficiency because of lowered levels of acid and hypomagnesemia. It is also predicted that PPIs are responsible for increased mortality potentially because of all these factors. However, one has to see very, very carefully in all these studies. These studies are all observational studies. And the odds ratio, which is mentioned in these studies, are very, very low. So to answer this question, whether PPIs are actually causing these kind of side effects, and we should look at alternate drugs. A large trial was designed, the multi-center trial, which was published in Gastroenterology in 2019, which is randomized in patients receiving the rivaroxaban or aspirin for heart disease or peripheral artery. So there were 17,598 patients included. 879 were received pantoprazole and 8807 received. There was a 3-year follow-up, and none of the complications mentioned was seen at a higher incidence in those who received pantoprazole, except enteric infection, which happened to be slightly higher in. Coming to the endoscopic management, surgical management has greatly evolved. So since wherever there is surgery, endoscopy cannot be far behind. There have been a number of endoscopic advances, but the two things which have been accepted for the last few years is Transoral incisionless fundoplication, which has 5 RCTs accordingly, still has low success rate ranging from 50 to 92%. Major adverse rate ranging from 0 to 4%. The other is the Stretta device, which is radio frequency ablation of the lower sphincter. Again, has 5 RCTs, 173 patients, variable results 15 to 100%, but very few. What is coming up recently is simple endoscopy techniques like applying bands to the lower sphincter, anti-reflux mucosectomy, like we do mucosectomy in EM, or simply ablation of the lower. So this is what the TIF device is. It goes into the stomach, through which endoscope comes and is retroverted. The device comes as a L. The cardia is pulled into the cell and sutures are applied over the creating a funnel-like structure here, which is the new alias. So this prevents any reflux from happening because the loose alias is now become tight. This is Stretta. Stretta is a balloon which has these probes. As the balloon is inflated, the probes go into the muscle like this. Then radio frequency ablation is carried out at these points, 5 centimeters above and 5 centimeters below the vein. And this results in fibrosis and tightening of the alias. This is very, very exciting because this seems to be very easy on as karma, anti-reflux ablation. The area around the lesion, leaving about 0.5 centimeters, is completely ablated for about 1 centimeter, leaving again about 30 degrees, and this results in a tight wrap once healing occurs. It is very simple because additional device is needed, and radio frequency ablation is something carried out in all industry on a daily. So that was endoscopic management of GERD. Coming to refractive GERD, there would be certain patients with GERD who are not responding to any kind of. So the approach here is optimization of PPI and lifestyle management, making sure that they are taking PPI half an hour to 1 hour before meals. If that does not work, going for pH monitoring. They have already had the pH diagnosis. Then the pH monitoring should be done by their own people. So the efficacy of PPI, the pH monitoring should be done along with impedance recording so that we know that whether it is just acid reflux or non-acid reflux, which is also happening to these people. And if PPIs do not have any effect on these patients, then they should be subjected to surgery. Probably these are the patients who should have who have a definite indication. Pregnancy is another area where GERD causes a lot of problems. The increased incidence during pregnancy due to fetal pressure. Heartburn is a cardinal symptom. You cannot do any investigation, including endoscopy or manometry. Treatment is by lifestyle modification, antacid and sucralfate, because both H2RA and PPI are category B drugs, which means that nobody knows what effect they have on the fetus, hence they should better be known. Finally, esophageal GERD symptoms, extraesophageal GERD symptoms, large number of symptoms that I told you earlier, sore throat, laryngitis, chronic cough, asthma, lupus, laryngitis, are all attributed to GERD. Evidence that GERD is causing them sparse, so one should evaluate for non-GERD causes before labeling these symptoms to be because of GERD. If no GERD symptoms exist, pH metry should be done before PPI. For patients with both extra and esophageal GERD, PPI per 8 weeks is recommended. Endoscopy should not be used to diagnose laryngopharyngeal reflux. So a lot of patients who have pharyngitis, they are diagnosed to be having a laryngopharyngeal reflux. This cannot be picked up on endoscopy. So if one has to do, then reflex monitoring is the test. Surgical or endoscopic procedures should be recommended only if there is a clear-cut objective evidence of fever. Thank you.
Thank you, sir, for that excellent talk. We'll take a few questions now. Dr. Batra, sir, my
Yeah.
question was when, because see, most of the patients which we have coming to our OPD have already been taking PPI. So in patients who have already been on PPI, when do you place your endoscopy?
So those who have already been taking PPI and they have a partial response or have not responded at all to PPI should be subjected to endoscopy. This is very clear in all them.
Perfect. And sir, regarding things which you said about biopsies, sir. So because same questions, like because they are mostly on PPI, so will you go for biopsy on patients who are already on PPI?
So we can stop PPI for a week and take biopsies, but stopping PPI is a must before you do that.
Right. So then this question.
While you are stopping PPI, you can treat them with antacids.
Right. So then this question is for Dr. Arun Prasad, sir. What are the indications of placing a mesh and which one do you prefer? Arun sir, are you there?
Hello.
Yes, sir.
Yeah.
So there is a question that what are the indications of placing a mesh and which one do you prefer?
Okay. So now if the defect is very large and you are not able to close the crura without tension. So because if there is tension of your stitch, then the stitches can cut through. So in these cases, we need to put mesh, and there are a variety of meshes available. There is what is known as a physics mesh, which is perhaps one of the best meshes available. It's quite expensive. Other than that, we also have regular meshes, which are dual mesh. One side we have a non-absorbable surface and other side is a smooth coated surface. So we can use that as well. For recurrent hernias, again, it would be a good idea to use a mesh because your crura is already weakened.
So then there's a question that what are the rationals, which you have already answered, sir, but what are the rationals of redoing Nissen fundoplication if it fails after some time?
Yeah, so I've already answered the question, but I'll repeat. A Nissen fundoplication, when done properly, there is absolutely no reason for it to fail. And the reasons for failure could be if you have not properly sutured the crura, or as I was mentioning earlier, you have sutured the crura too tightly. If your fundoplication is incomplete, you have not mobilized. So these are, surgical technical issues. So that's for any procedure. If not done properly, you can have recurrences. And we all know, even after a cardiac bypass surgery, you can still get thrombosis of the vessels all over again. After knee joint replacement surgery, the replacement can fail. So nothing is perfect. We cannot create what God has created. But I see that a Nissen fundoplication done for the right indication, done properly at a good center by a trained surgeon, the chances of recurrence should be very, very low.
Then there's this question by Sushil, sir. What sort of Mediclaim cover for robotic Nissen fundoplication, and is there any limits to it?
No, there is no limit. The limit depends upon what your insurance limit is. So if my insurance limit is 5 lakhs and the robotic fundoplication is costing 4 lakhs at a particular hospital, we get the approval. And if your insurance is 2 lakhs, then they will give you 2 lakhs and the remaining 2 lakhs you'll have to pay yourself. So that's like any other insurance.
Right, absolutely. So then this question is for Batra, sir. So when do you go for endoscopic treatment of GERD and when do you refer the patient to surgeon for further management?
Endoscopy is still evolving. The results of endoscopic treatment are still not perfect. So the indications remain the same as for surgery. For those who fail PPI therapy, they should be subjected to endoscopic therapy. Or those who have extraesophageal manifestations which have been clearly attributed to GERD, they should be subjected to endoscopic therapy. The third indication is those who do not want surgery.
Right. So then where do you place these drugs like the alginic acid in the treatment of GERD?
So alginic acid is a good drug and it is likely to become a PPI sparing drug. The only problem is that it is cumbersome and you have to take it twice a day. So possibly as more and more concern about PPI side effects comes in, alginic acid and H2RS would again become the drug of choice for managing.
Okay. And so then there's this about question about double dose PPI or single dose PPI. So when do you start single dose? When do you switch over to double dose PPI?
So you use the minimum dose of PPI. However, if it is a partial response, then you have two choices. Either you switch over to another PPI or you increase the dose of PPI to make it a double dose PPI.
If there are no further questions, can I ask Dr. Sushil Jain to do the vote of thanks?
Okay, so
Hello.
I would like to thank, sorry, there's someone trying to speak something.
Yeah, hello.
Yes.
Am I audible?
Yes, sir. you are.
Yes, Dr. Midha, we can hear you.
Yeah. My
Dr.
question
Midha,
is
we can
that.
hear you.
Hello. What is the role of dietetics in the management of GE? Because most of the times I have seen GERD is associated gastric also. Hello.
Sorry,
Hello?
could you repeat that again? Hello?
Actually, I'm asking what is the role of gastroprokinetics in the management of GERD? Because several of the times GERD is associated with gastroparesis also.
Yeah, Dr. Batra will answer that.
Correct. So unless you have demonstrated gastroparesis, there is no role for prokinetics. And even to demonstrate
No, I'm talking of a patient. I have had demonstrated case of gastroparesis along with the GERD. What will be the role of gastroprokinetics and anything else we could add to it to gain more advantage?
No, then you use a combination of prokinetic along with PPI, and you could also use drugs like erythromycin.
Erythromycin.
Yeah.
But erythromycin orally is not very effective. You need to add in the form of IV and very high.
IV is not available. You only have a choice of using it orally. That also for short periods of time. And antibiotics you can't go on. So essentially, you choice is only restricted to prokinetics.
Okay. And one more question, sir. I have a patient who is on methotrexate orally since last 3.5 years. Hello?
We can hear you.
Voice is breaking, sir. Hello?
Yeah, methotrexate for the last 3.5 years.
And the patient, I have established that this is gastroparesis and GERD is because of the cumulative toxicity or side effect of methotrexate.
Okay.
So now my question will be, if I stop oral methotrexate and put the patient on injectable, subcutaneous or intramuscular methotrexate, will it give some relief or will be the same?
It would be the same. But how are you establishing gastroparesis?
Not able to hear, sir.
I'm saying, how do you
Hello?
establish gastroparesis in your patient? Just as a learning tool.
because I have tried each and every treatment, name it PPI, name it gastroprokinetic, name it sucralfate. But once I stopped methotrexate for 3 months, then only the patient responded and said that I don't have symptoms now.
Okay. So even for establishing gastroparesis, you need the scintigraphy or you need the EKG. So without that, again, we're just assuming that this is. So both these things
But
are
my
valid.
question remains, patient.
So switching over to IV, yes.
IM or subcutaneous. Will it help?
No, it will not. It will
But
not.
you are, sir, you are bypassing the oral route now. It should have some
Yeah,
good
but the
effect.
changes which are because of the drug are not because of the changes in the gastric mucosa. It is because of the reduction in motility.
Okay. Reduction
in the motility, which happens because of the drug itself.
So motility will be.
It is not that the drug
So
is being.
what you mean to say? What you mean to say is that the motility is affected whether it will be oral route or it will be injectable route.
Correct.
Motility will have the same manifestation.
Correct.
So, but sir, actually, along with paresis, you see, patient develops meningitis also. The damage to the internal lung of the stomach and that part is, I think, direct injury to the gastric mucosa when taken orally, methotrexate taken orally.
So if there are florid ulcers, it might help.
No, there are no florid ulcers. No florid ulcers.
Yeah, in that case, it is not going to help. This is similar to NSAIDs taken intravenously, for example. So
Okay.
it is not direct gastric injury. It is the propensity of NSAIDs causing injury to the gastric. They still can cause ulcers.
So you mean to say whether you give oral or you give parenteral, it will cause gastroparesis.
Correct.
Either way.
Correct.
Okay, sir. Okay, thank you.
It's very good.
Okay, so since there are no more questions, I would like to thank Dr. Arun Prasad and Dr. Batra for the interesting topic which they have taken up, and it's a common topic which would be of interest to everybody who has participated. Thanks to all the participants, the GAPIO team, Mr. Jiten, and the chairperson, Dr. Avnish, who has moderated the whole session beautifully. I would also like to thank the IT team, which is acting behind the scenes to get these sessions organized for us. So thank you, everyone, and we look forward for many more sessions like this. Thank you.
Thank you.